Block 2, talking about primary hypertension and kind of the medications, first-line medications we have in order to treat hypertension. Today we're going to talk about secondary hypertension and hypertensive crises type of conditions and how to treat and manage those. But let's just do a couple of check-on learnings from yesterday's material first, and then we will move on with the new material. So our first one was, which of the following is not an identified risk factor for essential hypertension? Correct. That's actually the best treatment, lifestyle treatment, right, for essential hypertension. So not a risk factor, but does it make sense that all these other things are risk factors for hypertension? Age, as you get older, more likely to have hypertension. Inactivity, so here's the couch potato. Going to have risk of hypertension because it's going to lead to obesity. And then, of course, smoking doesn't really do a body good, so for anything. So that's always a risk factor. Our next one was, what blood pressures are needed to diagnose stage 1 hypertension in the ACC-AHA guidelines or definition? Okay, I'm seeing C or Charlie. Does everybody agree with that? Yeah, I would agree with that too. So stage 1 in the ACC-AHA is at 130s over 80s. Stage 2 is 140s over 90s or higher. Okay, which is different than the other societies where they don't diagnose stage 2 hypertension until it's greater than 160 over 100, right? So, but according to the ACC-AHA, stage 1 is this. Stage 2 is actually the letter delta on that. So,
Do you think the stages are built because of big pharma's money grab?
That's always something to think about. But what I will say is most blood pressure medications are not owned by big pharma anymore, meaning that the generic drug companies are now actually producing the vast majority of our antihypertensives, and they make pennies on the dollar for each pill. So like 30-day supply of lisinopril is like $4. The pharmacies, they have to tack on some of theirs, so it gets up to like $7 a month kind of thing. But it's not a big money maker in that regard. Now, if it's a brand new medication and it's brand name, and Pfizer or some of the other big farm companies have it, then yeah. I mean, they do things like tweak the molecule a little bit so they can now market this enantiomer as the latest, greatest when they lose their patents on other things. We saw that with Prilosec, kind of a great example, PPI. Prilosec was the big thing. It worked great for acid reflux. Then they lost the patent, and they just tweaked the molecule a little bit, made Nexium, and then they marketed it as a better option than Prilosec. So now they own the patent, and they could market it off of that. So you do see that, but with most of our antihypertensives, they've been around for so long that the big farm companies actually don't own it. And most likely it's usually a Chinese company that owns it and produces and puts all kinds of stuff in it. So. Last check on learning is a 68-year-old man presents to his physician for reevaluation of an elevated reading on his home BP monitor over the past 6 months. His past medical history is notable for type 2 diabetes with microvascular complications, including diabetic nephropathy. In clinic, his blood pressure is 165 over 80. A diagnosis of hypertension is confirmed, and a decision is made to initiate pharmacologic therapy. Which of the following would be a preferred choice of antihypertensive medications for this patient?
B.
Okay, Bravo. Why an ACE inhibitor?
Diabetic.
Yep. Diabetic with kidney disease probably should be on something that's going to preserve kidney function, and ACEs and ARBs are great for that. So B is the correct answer on this one. So good. All right, so another clinical case to kind of open our talk for today, or our topic for today. This happened at Fort Belvoir when I was a resident there. I was the admitting resident for the hospital. And I got called by the ER for a 32-year-old, otherwise healthy female marathon runner who presented to the ER for headaches. On labs, she was found to have an elevated creatinine. IV fluids were given with mild improvement in the creatinine, but it remained still greater than 2.0. ER staff contacted me to admit her to the hospital for acute kidney injury, and the ER provider, quote unquote, said vitals were normal. Belvoir at the time in the ER did not use electronic records, so I couldn't verify that until I went to the ER and opened the paper chart. But I did my thorough review of her history, pulled all of her labs, started the process to get her admitted to the hospital, and then I went to go see her. And I start flipping through the charts, and I see on her triage vital signs, her blood pressure was 230 over 120. They gave her a clonidine patch, but repeat blood pressure after clonidine was started was still greater than 180 over 100. So I ended up actually refusing the admission to the hospital for a couple of reasons, but the primary reason was the level of blood pressure to be admitted to the hospital ward versus going to the ICU was the blood pressure had to be less than 180 over 100. So anything more than 180 over 100 had to go to the ICU. Okay. So I went and talked to the ER provider. I confronted him with the data that I saw in the paper chart. He's like, oh yeah, I forgot. So not a very great management of your patient if you forget that they had hypertensive crises. We'll talk about that today, definition. And we'll talk about, we'll revisit this, but we'll talk about which specific hypertensive crises condition she actually had. So let's start with talking about secondary hypertension. So we said essential or primary hypertension is hypertension where we can't have a distinct identifiable cause. So secondary hypertension is the opposite, where now we have an identifiable cause. So instead of hypertension or that elevated blood pressure now being the condition, it is now a symptom of the condition, okay? And that's important to know because if I just give antihypertensives and there's something else out there that is causing this, I'm not really adequately treating her, right? Or treating the patient because I'm only treating the symptom. That's like you've got a sore throat because of strep and I just give you Motrin to treat the pain, right? I'm not giving you the antibiotics to treat the infection part that's actually causing the pain. This is what happens with secondary hypertension if you just solely focus on treating the number. So who should we suspect as having secondary hypertension? We said about 90% of patients have essential hypertension, but who should we suspect as having secondary hypertension? And there's a couple of things that you can look at. One is, what was the age of the onset of the hypertension? If you have an adolescent or a pediatric patient, be thinking of secondary causes. And we talked about one of those in block 1. We'll talk about it again today, but coarctation of the aorta, right? If the blood pressure elevations developed after the age of 50, now we should suspect secondary hypertension. We'll talk about the main one that presents in your older populations, your elderly populations, where they went through their 20s, 30s, 40s without blood pressure issues, and then they developed it. Okay. Another thing would be how quickly that blood pressure came on. Is it a year ago I saw you and you were like 139 over 88, and then a year later you come in for your annual follow-up and now you're 141 over 92, You see that gradual increase. That shouldn't make you suspicious for secondary causes. However, what should is if they had a normal blood pressure 6 months ago, and now they come in and it's 160s over 105 or more, or whatever. That quick rise in blood pressure should be concerning that there is something else going on that's causing that blood pressure to be elevated. So those are just a couple of things that could and should make you suspicious for secondary hypertension. Here's a list of all the acknowledged causes of hypertension and kind of their incidence rates. Now you see, okay, we say 90% is essential, but when you look at primary aldosteronism, look at that range. And that's based on the studies that we have. And you'd be looking at it and be like, how can you get above 100%? Reason for this is we are becoming better at testing and having different tests available to us to actually diagnose primary aldosteronism. So actually a lot of the cases that we thought were essential hypertension are actually being shown to be a secondary form, primarily primary hyperaldosteronism, which we'll talk about today. But then you can see all the other things. So pheochromocytoma is only 0.2% of cases of hypertension, so a rare cause of this. But we'll talk about each one of these forms today. The other thing that you got to think about, though, if you have a new patient, or if you have a patient with new diagnosis of hypertension, is maybe it's we are doing this to them. What are the medications that they are on, and could that be playing a role? Probably one of the most common forms is our estrogen-containing contraceptives. Estrogen can raise the blood pressure. So maybe if we have a patient we've been watching their blood pressures are creeping up, maybe we should try to switch them off of an estrogen-containing contraceptive to something else. Other things, so alcohol, we talked about that being cardiotoxic. Folks who drink excessive amounts of alcohol are going to be at risk for it. So there are some additional lifestyle things that could cause that blood pressure to be elevated. But let's talk about the specific secondary cause conditions and how they contribute to blood pressure elevations. We're going to break it down into renal causes, adrenal gland causes, coarctation, endocrine, and then other causes, okay? But we'll focus first on renal. This, in literature, is considered the most common cause of secondary hypertension, although the primary aldosteronism is now becoming more prevalent in newer studies. But there's two kind of flavors to renal causes. There's problems where the blood vessels going to the kidney is the problem. And then there's the problem of the nephron, or the vasculature in that nephron that's causing the blood pressure issues, okay? So you can kind of divide them out into those two main groupings. When we're looking specifically at the blood vessels coming into the kidney, there's two main causes of this. If you have a young woman coming in with blood pressure issues, then be thinking of this fibromuscular dysplasia. So you have this inappropriate overgrowth of the cells within the lumen of the vessels themselves, which narrows it, and then that disrupts that blood flow, that perfusion coming into the kidney. If you have an elderly person, especially elderly male, who's coming in now with new blood pressure, then you got to be thinking about renal artery stenosis, where this person has atherosclerotic plaques that are now building up in those vessels leading to the kidney, and that is disrupting the blood flow to the kidney. Well, why does that cause blood pressure problems? Well, it comes down to the self-preservation that the kidney wants to, fight to make sure that it's getting the perfusion that it needs. So it senses that reduction in flow, so it activates the RAS, and then that increases your aldosterone levels, that increases your vasoconstriction with angiotensin II, and now you're increasing the tone, but you're also increasing your stroke volume, i.e. your cardiac output, because you're keeping all this extra fluid, keeping all this sodium, chloride, and everything like that because of that aldosterone. So it's through the RAS system, the kidney activates its self-preservation mode. Now compare that form of kidney-induced hypertension to this form, where it's the nephron itself that's the problem. Okay? And it usually comes from damage from other conditions like poorly controlled diabetes, and now they have diabetic nephropathy. So now you're not filtering out fluid appropriately. You're not regulating that balance of your volume appropriately, and you start to see a decline in the kidney function because of this. So your creatinine levels start to go up, your urinalysis is abnormal because of this damage to the nephrons because of these conditions. That point kind of helps you also differentiate it from the previous versions, because the other versions with this renal vascular disorder causes, these don't have an abnormal kidney function because the kidney is going to work with whatever volume gets there. It's going to filter out those toxins. It's going to regulate the parameters, the electrolyte levels, the fluid levels. It's going to regulate all those things. It just is having problems getting blood to it in the first place. With the parenchymal disorder ones, with like diabetic nephropathy, the actual filtering system is broken, and that causes a decline in renal function. Okay. So let's move on to your adrenal glands, because these are the versions of secondary hypertension that your tests are going to love to put questions on your test for these. So you got to know these forms. I know you've started endocrine, so there may be some overlap with what I talk about and what Colonel Heater talks about, but we'll focus it on more from whether the effects on the blood pressure values. So we know about the RAS system. We know how we have this breakdown of angiotensinogen into angiotensin 1, into angiotensin 2, and how now angiotensin 2 is the active form of this hormone, and how it works by causing vasoconstriction, but it also then goes and acts on the adrenal gland and causes the secretion of aldosterone. And then when we have that secretion of aldosterone, that then goes and acts on the kidney, and particularly the sodium ATPase, sodium potassium ATPase pumps, where now I'm grabbing sodium out of the urine and I'm dumping potassium instead. This is the regulated system, right? You need all these other upstream effects to happen to cause that production of aldosterone. But let's say we have a condition where now that feedback loop, that regulatory cycle is disrupted, and now I have the ability to just produce aldosterone without any feedback. And you'll see this in a number of conditions where it could be that you have a benign tumor in the adrenal gland that's just producing aldosterone. It's called Conn syndrome. It's the most common form of this, and this is actually what my mother had that was undiagnosed or misdiagnosed for 20 years until they were able to find it. But because I've lost that regulatory feedback on regulating the levels of aldosterone, now the same effects happen. I'm not necessarily having that angiotensin 2 causing the vasoconstriction. But now I'm having that hyperaldosterone production causing the hyperretention of sodium and water, increasing my vascular volume, which then leads to your blood pressures being elevated. Okay. One of the key findings with this, because we're working on that sodium-potassium ATPase pump in the distal convoluted tubule of the nephron, is we're dumping potassium like crazy in order to reabsorb that sodium. So the most common kind of presentation you're going to see in somebody with hypertension is that their potassium levels are low, because we're getting rid of that potassium. We're not regulating that electrolyte level appropriately, because you have this bypass of the normal regulatory system. So if you see hypertension, patient with hypokalemia, you've got to be thinking hyperaldosteronism. Okay. But if you wanted to actually have the official diagnosis, what you would do is you would initially do a 24-hour urine collection and test for aldosterone levels in that urine. So basically the patient just carries a jug around with them and they collect all of the urine over that 24-hour period of time, and then we'll test and see how much aldosterone is in that. The confirmatory test is then to actually do this serum aldosterone to renin ratio. Okay? And usually a high ratio confirms this, because if I have a benign tumor that's causing the hypersecretion and production of aldosterone to the point where my blood pressure is elevated, the RAS system is going to try to shut down that process, right? Because it's going to detect that the blood pressure is too high. I need to shut down the RAS to lower my blood pressure. So you're going to stop releasing renin. The kidneys are going to stop releasing renin. But because that tumor doesn't respond to angiotensin II necessarily in order to produce aldosterone, it's still going to produce and secrete that aldosterone level. So you'll see that ratio is going to be pretty large of aldosterone to renin. Now, let's say though that the renin, or aldosterone to renin ratio is not that greater than 25:1, but you have that elevated 24-hour urine aldosterone. Well, it could be that if that ratio is not greater than 25:1, then it could actually be due to this condition where there's this rare renin-secreting tumor. So instead of it being an aldosterone problem, it's now a tumor that's inappropriately hypersecreting renin, which is inappropriately activating the RAS. Okay? So if that ratio is not greater than 25:1, then maybe be suspicious. But you suspect that there is hyperaldosteronism because of that 24-hour urine aldosterone level, then be suspicious for this secondary hyperaldosteronism because of that renin-secreting tumor. And this is just a little cartoon graphic that shows that the level of where aldosterone works in the distal tubule, and it causes the reabsorption of sodium at the expense of getting rid of potassium. Okay. The next adrenal gland cause of secondary hypertension is Cushing's syndrome or Cushing's disease. Apparently, dogs can get it. This is a picture of my dog that soon after we moved here was diagnosed with Cushing's disease. So, dogs can get it. And the only symptom they had initially was she was having protein in her urine. They don't normally take blood pressure for animals, right, when they come in for the vet appointments. So we had to bring her in for a blood pressure check, and sure enough, her blood pressure was elevated. So she was put on medications to treat Cushing's disease. But, so what exactly is Cushing's syndrome? Kind of think of it as there's this hyper secretion or elevated levels of glucocorticoids, particularly cortisol, that is circulating and not being regulated. The levels are not being regulated appropriately. And ultimately, that cortisol or those glucocorticoids cause an increase in blood volume. So you're increasing your blood volume. So you're increasing that stroke volume because you have all that basically that stroke volume there. And then it also causes a renin production, hyperrenin production. So now you're activating the RAS system as well, which then further causes you to absorb, reabsorb, and have an even higher blood volume. Okay. But there's a number of different reasons for this cortisol level being elevated. Is it something primarily like in the adrenal gland that's causing the hyperproduction of cortisol? Is it we're taking medications or we're taking supplements that have cortisol in them? Watch out for your GNC workout supplements because they put all kinds of crap in those things to help with performance. And most patients, if 1 scoop works, 3 is even better. And they they overdose on these things, which then can lead to problems. Okay, I've seen this before with hyperthyroidism because there was a supplement that GNC was producing that actually had thyroid hormone in it, and the person was taking like 3 to 4 scoops of it when the recommendation was 1, and they came in with thyrotoxicosis. Okay, so I've seen this from workout supplements before. Okay. But another cause of that elevated cortisol level could actually be that we have a pituitary adenoma that is secreting ACTH, which then goes and acts on the adrenal gland to cause the production of cortisol. So you release excessive amounts of cortisol, and then that cortisol then acts and causes the increased blood volume, increased renin production and everything like that, and leads to the blood pressure problems that we see with Cushing's. The way you test this is you can do the dexamethasone suppression test. So I give a glucocorticoid. Let's see if our cortisol levels go down. Because that would be a regulated system. If your body senses that it has an excess amount of glucocorticoids, it's going to shut down the regulatory process for that, right? But if I have a tumor that is producing cortisol on its own without that regulation, without that feedback, then what happens is I give them this huge dose of dexamethasone, but they still produce that cortisol. Okay. Another test, the confirmatory test, is to do the 24-hour urine cortisol level. So again, have the patient collect their urine for 24 hours and test the cortisol levels in that urine sample. But what's also unique about Cushing's syndrome is you could actually diagnose this without any laboratory tests because there's actually physical exam findings that you can see with your patient. Okay? So kind of the common ones are going to be like this buffalo hump that you'll see because you get like a hyper-fat kind of deposition here in that area. You also tend to get this red stria, so they get like these red stretch marks appearing kind of things. And then they also get very thin skin, and they're easily bruisable, and they tend to have that moon facies. So if you ever have a test question that starts to describe physical exam findings such as this, it's Cushing's. Okay, all right. But there's lots of causes for this. So you've got to, when you have a patient with Cushing's, you've got to determine, well, what is the cause? Is it we're giving them excess steroids because they have like a rheumatologic disorder and they need steroids? Is it that there's a tumor that's producing this excess cortisol levels in the adrenal gland? Or is there something in the pituitary gland that's causing the ACTH hypersecretion which contributes to the cortisol levels being elevated. Okay. So that's the second version of adrenal gland disorders causing secondary hypertension. The third one is pheochromocytoma, probably the rarest form, but I can guarantee on your pants you're going to have a question about a pheo, because they love testing about pheochromocytomas. Okay? So pheochromocytoma, the cause of this is this hypersecretion of catecholamines from neuroendocrine cells. Okay? So you kind of think of it as like this neuroendocrine tumor that starts to produce catecholamines, so like epinephrine and norepinephrine that are not regulated by the normal systems. And what can happen with this is I can be fine, and then all of a sudden I get this surge of epinephrine or norepinephrine or even dopamine that enters my bloodstream, and then it's going to cause the blood pressures to go up. So a lot of times what ends up happening is patients with pheochromocytomas tend to present with this triad where they have this episodic headache because right now my blood pressure is okay, but 20 minutes from now when I get that catecholamine surge, that blood pressure is going to go through the roof, and now I get a headache. Okay? Sweating, because now you're having all these extra catecholamine sympathetic kind of response, right? It's going to cause sweating. And then tachycardia. Okay? Again, the sympathetic overdrive kind of thing leads to the heart rate to be elevated. But these patients, they may present to their primary care doc yesterday, and their blood pressure was 110s, 120s, over 60s, 70s, completely normal. The very next day, they're presenting to the ER, and they're 230 over 160. Okay, that's how drastic and how quick this could occur. So don't be falsely reassured of, oh, you're coming with me with this severe elevation in your blood pressure, but yesterday it was fine, so it can't really be that big of a deal, right? No, it could be that now that tumor that's producing those catecholamines just did a surge release of those catecholamines, which is then contributing to this. But the way you test for this is doing this 24-hour urine fractionated catecholamines metanephrines. So metanephrines are basically the breakdown products of your catecholamines, okay? But you do a urinary fractionated test for that, and then an elevation in those levels confirms the diagnosis of pheochromocytoma. This neuroendocrine tumor, though, isn't necessarily localized to just the adrenal gland, okay? Most commonly, it's there. But if you were to do abdominal imaging, particularly looking at the adrenal glands, and didn't see anything, don't be falsely reassured that this can't be pheo, because it could be located anywhere on the sympathetic chain. So you got to actually do kind of more of like a head to a pelvic kind of imaging, looking at the sympathetic chain, looking for this tumor that's causing this hypersecretion of catecholamines. Okay, coarctation of the aorta as a means of secondary hypertension. We talked about this in the congenital heart disease lecture. We talked about how typically you're going to see hypertension in a pediatric or adolescent patient, and that's unusual to have hypertension, although unfortunately because of childhood obesity rates, which we have in the United States right now, we're starting to see essential hypertension developing in pediatrics. So don't be like, you've got a pediatric, it has to be coarc. Okay? Unfortunately, our population is becoming more and more unhealthy, which is causing these adulthood diseases to start developing in our pediatric populations. But recall from the congenital heart disease lecture how some of the things that you might see in a patient with coarctation is you're going to have hypertension in the upper extremities, but you could have normal to hypotension in the lower extremities because you're not getting that perfusion or a normal level of perfusion down into the lower body. Okay. The other things you might see is going to be like rib notching on the X-ray, and this is why. So here's a CT reconstruction of somebody with coarctation of the aorta. This arrow is pointing to that coarc, but look at all of these really hyperdilated, enlarged arteries, intercostal arteries. They're trying to get that blood that's not going into the lower body, trying to get that blood around that obstruction. So it's using other arteries to kind of get down, but it's having to see a much larger volume than normal. The top right picture there is just a gross anatomy transection of a coarc, where you get this narrowing right here. Here's your arch of the aorta, and then your narrowing is right there. Here's an angiogram version of that. You can see here's your aorta coming down, and then there's the narrowing right there. That shouldn't be there. Chest X-ray. So the red arrows show your rib notching that you see, the undersurfaces of the ribs, that notching present there. Here's your aortic knob, which that does not look normal because that should continue down like this, right? But because of that coarc, you get that little indent there, and then your aorta then opens back up post-coarc, okay? But unfortunately, depending on the severity of that coarc, it may not be getting much volume of blood going into the descending aorta into the abdominal aorta. You've started endo. It's a little unusual that you all start endo this early in the semester, so it's kind of exciting because maybe we'll be piggybacking on a lot of this stuff. But endocrine causes have a profound impact on blood pressure. We already talked about the adrenal gland things, right? But hyperthyroidism tends to cause kind of an isolated systolic blood pressure elevation. It's interesting. What was even more interesting is hypothyroidism, which normally we think of, depression, constipation, cold intolerance, and edema as our symptoms of hypothyroidism. But you can also add one of the symptoms of hypothyroidism is a isolated diastolic elevation. So this would be your patient who, their systolics is like 110s, 120s, but their diastolic is 94. Simply seeing that kind of disparity between the systolic and diastolic should make you a little suspicious for hypothyroidism. And regardless about what the patient is coming in for, maybe you should test their thyroid levels to make sure that they don't have hypothyroidism. Hyperparathyroidism. So what do your parathyroids do? Regulate calcium levels, right? So if I have hyper, I'm secreting excessive amounts of parathyroid hormone, which is causing an excessive levels of calcium. We talked about with our calcium channel blockers how they lower your blood pressure, but now think about it as the opposite. So in calcium channel blockers, we reduce the level of calcium, which then causes that vasodilation, right? Because the muscles can't contract without that calcium. But now let's give an environment where I have excessive amounts of calcium. Now, what is that going to cause at the level of the blood vessels? It's going to cause a hyperconstriction, right? Because now I'm giving this excess amount of that required product in order to constrict. And that's what happens with hyperparathyroidism. You get this hyper inappropriate contraction of the blood vessels, which then leads to increasing that systemic vascular resistance. Okay, and then let's go into our catch-all category of secondary causes. So obstructive sleep apnea, super common. Of course, everyone wants to get diagnosed with it before you leave the service, right? Although I think the VA is starting to reduce how much they pay back or pay you for disability with OSA. But there is real problems associated with sleep apnea, okay? It's more than just a paycheck at the end of your service. Sleep apnea, you're going through periods of time where you're becoming hypoxic when you're sleeping, right? And you don't know that this is going on. You aren't aware of it. It's subconsciously all of this is happening. So typically the patient themselves have no idea that this is happening. But usually it's their significant other, their spouse, or you're deployed and you're sharing a room or a tent with multiple people, and then they're always complaining about how loud you are when you sleep. That's how patients become aware they have sleep apnea, is people complain about them. Okay. But these periods of time where you're experiencing hypoxic episodes causes a stress response, which then causes a hypersecretion of cortisol. And remember, we talked about cortisol levels in Cushing syndrome, right? Same thing kind of happens with sleep apnea. So if a patient has sleep apnea and they have hypertension, simply starting them on a CPAP could then actually manage their hypertension even without giving them a pill for their blood pressure. So you're treating the cause, which then leads to reduction in cortisol levels, which then leads to a normal resumption of blood pressure. So sleep apnea not being treated with CPAP can cause elevated blood pressures. We talked about medications that can cause this, like estrogen-containing medications can cause elevated blood pressure, so be careful of those things. Things like Sudafed, it's cold and flu season, right? Sudafed is being given around all over the place, but that can cause blood pressure elevations too. So part of your history, when you're taking that history, especially that medication reconciliation, you've got to include those over-the-counter drugs, because it could be that their hypertension that they're coming in right now with is because of that Sudafed that they took and not because they have hypertension. Alcohol we talked about, but cocaine and amphetamines can also cause that elevation, right, in blood pressure. And when we talk about hypertensive crises, we'll talk about we'll talk about them and how they can cause or precipitate these hypertensive crises simply by overusing those compounds. But remember when we talked yesterday how hypertension normally doesn't have any symptoms. It doesn't have any negative symptoms associated with it, so it becomes very difficult to manage because patients don't think they have a problem. But that blood pressure, just because it's asymptomatic now, does not mean that damage is not being done. There's damage being done that we will only see 10, 15, 20 years from now. And these are the types of things that you're going to see. And these are the types of things you're going to have to counsel your patients on why it's important to manage their hypertension. So ultimately, okay, I can increase my afterload. Well, what does that lead to? Well, I get left ventricular hypertrophy, which then leads to diastolic dysfunction of the heart, which then leads to heart failure. Probably not something that 40-year-old, 50-year-old wants to experience, having heart failure, congestive heart failure, right? It can also cause a systolic dysfunction, which then can lead to heart failure. But it can also increase your myocardial oxygen demand, which then could lead to an MI. So now they're having heart attacks at the age of 40 or 50. Do they want to have a heart attack and potentially die at 45? That's the afterload side of the house. But let's look at what's happening to the microvasculature. Okay, I can accelerate my atherosclerosis development because I'm causing all this damage, and we'll talk about on Thursday about atherosclerosis lipid disorders. But that atherosclerotic plaque formation leads to somebody developing a heart attack. It also can lead to strokes or other peripheral arterial thrombotic diseases. And we'll talk about a good example of this in our 6th lecture of this block that I was a part of when I was a surgical intern about a thrombosis affecting another major artery. It can also cause aortic aneurysms and dissections. It can then lead to kidney disease, so they may need to be put on dialysis, which, now you're talking about several hours, 3 days a week, 4 days a week, getting dialysis hooked up to a machine. And then it can also cause them to go blind. And I've seen this before. When I was a medical student, a patient with hypertension and diabetes thought her providers were quacks. She wasn't feeling any symptoms. She took it upon herself to stop all of her medications. 3 years later, she comes back. She can't see. Her vision, the retinopathy had deteriorated, or had gotten so severe that she needed to read. She needed letters almost the size of a sheet of paper with a magnifying glass to actually be able to read the letter, simply because she stopped her medications for her blood pressure and for her diabetes that led to retinopathy. So there are long-term major consequences that your patient can experience if they don't manage their blood pressure today. We have about 4 minutes, or 3 minutes, and then we'll stop for our break. But let's move on from the secondary hypertension, and let's start talking about hypertensive crises, okay? This term is still the same in the 2025 version of the ACC-AHA hypertension treatment algorithms. They do change the term hypertensive urgency, but the most of the stuff is still the same in the 2025. Unfortunately, the PANCE is going to test you on the 2017 stuff. But when you get to phase 2, you're going to be expected to manage patients like the 2025 version. So you just have to be, unfortunately, familiar with both. Our test here in class will be on the 2017 version of this, okay? So what exactly is hypertensive crisis? It really boils down to a clinical situation where the patient's blood pressure is elevated greater than or equal to 180 over 120, okay? And there's 2 main versions of this. It could be hypertensive urgency, which the new guidelines call it markedly elevated, where you have that systolic and diastolic elevations, but there's no evidence of end organ damage, okay? They could be completely asymptomatic with that severe elevation, or it's okay for them to have a headache, a nosebleed, and maybe even feeling faint. That is not considered end organ damage in the setting of that elevated blood pressure. But compare that to hypertensive emergency, where you have that profound elevation, but now you can detect end organ damage related to this, okay? So one has that severe elevation without end organ damage, and then one version, the more severe version, has evidence of end organ damage that shows that those organs are under stress because of that severe elevation in blood pressure, okay? And we'll talk about those when we get back from the break on how to diagnose and manage those conditions. So let's take 10 minutes.
Today's first slide.
But
Just leaves this here. No, I ate mine eating that. And I got it wrong. But I still got it wrong.
Where's my truck?
Yeah, we literally have the same one. The same thing.
Oh yeah. I just got a different color.
Yeah, in order to be on this road, you have to white concrete tape back. You got rooted. Sort of like a physical separation. Got it. Keep it sitting around. If I told you, it would make you sad. So. But it was, yeah, it was, no, my wife made it. I was all the siblings to make one, for a celebration of life, and I was like, not my forte. I said, wife, you're the artist. I said, you paint this one. Yeah.
$700 just for the rest of the like December. Yes, his cousin,
I don't think we're out.
Senator to a Christian university.
Oh, you're doing church stuff too? Are we open to it? His first test? Yeah. We've been planning. It's too much to just be writing every time I'm like, okay, I would back to it. I know my history, so we
Alright, I got 9 o'clock. We're back to our talk about hypertensive crises. Okay. So we talked about hypertensive urgency, we talked about hypertensive emergency and the definition of those things. Some other kind of different flavors of hypertensive crises that you might see is this accelerated malignant hypertension that affects the retina. And you can kind of get an example of what the retina might look like. Good luck using your ophthalmoscopes to see that without dilating the eyes. So good luck. The other version is, hey, somebody comes in with severe elevations of their pressures and they're having a coma. Well, that would be hypertensive encephalopathy. Okay. So it's just some different kind of versions. But you can see, though, would you say that that's end organ damage? Yeah. So it kind of fits under the umbrella of hypertensive emergency, right? But when you have a patient that comes in with hypertensive crisis, you just see that profound elevation of systolic and diastolic. You don't know if there's end organ damage yet. This is where you have to do your history and your physical to kind of ascertain whether or not end organ damage is present or not. And this is important because I need to have that correct diagnosis to treat it. And when we talk about the treatment of hypertensive urgency versus hypertensive emergency, you'll see how if you misdiagnose hypertensive emergency as hypertensive urgency, there could be some profound long-term consequences related to that, okay? So you've got to make sure you correctly establish the diagnosis. So in your history, look for any evidence of symptoms of end organ damage, which we'll talk about, I think, on the next slide. Then you got to start asking them, are they supposed to be prescribed medications, but they stopped them for some reason? Because that's one of the more common causes of hypertensive urgency is patients run out of their hypertensives, can't afford to buy their new prescription, or they're having problems getting their provider to give them a new prescription, and then they come in with that profound elevation of their blood pressure. Are they on supplements or other over-the-counters that's causing this? We talked about GNC stuff, but supplements are there, they're real. We talked about illicit drug use, so like cocaines and amphetamines can cause this. And an example of amphetamine is, yes, Adderall that's being prescribed for ADHD or ADD, but a lot of our adolescents are having these pill parties where everybody just brings in their prescription meds, dumps it into a bowl, and then you just sit there and take turns trying all everybody's other meds, right? So you see that in college too.
Oh, yeah.
So what happens if somebody's popping mega doses of Adderall that they've never been on before? They could come in with a hypertensive crisis, okay? So make sure you take that history. Have they ever been treated for hypertension before? Have they ever had this experience before? Because that will help you with your diagnosis. Your physical exam, okay, repeat the blood pressure to make sure that it actually is real, right? Try to do fundoscopy, but again, good luck. You may need to call your eye specialist down to the ER in order to do a thorough, proper retinal exam. Check their cardiopulmonary status. Yes, if they're in extremis, then probably waiting for the optometrist to come down and see your patient is not the correct answer. You're going to want to manage those life-threatening things first, right? But look for evidence of end organ damage. And here's a list of signs and symptoms that are consistent with end organ damage based on the organ, okay? The brain kind of makes sense. We said headache doesn't count as evidence of end organ damage, but if I have any kind of neurodeficits, such as altered mental status, lethargy, ataxia, confusion, seizure, all of those are evidence of end organ damage. That pressure elevation is so bad that it is affecting the normal function of the brain. Okay? When we look at cardiac, okay, left atrial, left ventricular hypertrophy. Okay, those are not an acute thing. That tells me that this is something that's been going on for a while, right? Ischemic chest pain. So we'll talk about ischemia in our fourth lecture, what ischemic chest pain is. It's not a normal like stabbing kind of pain that you think of, but if it's like a true ischemic chest pain, that is evidence that there's end organ damage. This includes a heart attack, so myocardial infarction. They could come in with a myocardial infarction because of that blood pressure elevation. Kidneys, so if we start to see abnormal kidney function, that's indicative of end organ damage. Vascular would be things like a tearing of the aortic wall. But the eyes, you can see like this AV nicking, cotton wool spots, all those things in the retina are examples of end organ damage affecting the retinas themselves, okay? Because that's going to lead to vision problems, okay? What's our primary things for triage? Life, limb, or eyesight, right? Same goes with this in a hypertensive patient. There's a couple of other hypertensive conditions that we're not going to talk about here, preeclampsia and eclampsia, because you're going to be talking about these in the context of a pregnancy with a severe elevation of blood pressure, okay? We'll talk about the management of these conditions, but we're not going to actually talk about the specific condition. Wait till next semester when you're in women's health, okay? So what do? You have that patient, you properly diagnosed them with a hypertensive crisis, you've properly identified if this is hypertensive urgency or emergency. What do we do next? Okay. Well, fortunately, most of the time, when somebody comes in with a hypertensive crisis, they already have a history of hypertension, but for some reason, whether it be they stopped their meds, whether it be now they're sick, severely ill, or something causes that severe, that profound elevation, so that acute on chronic elevation of their blood pressure, okay? And there's an algorithm that the ACC-AHA has put out to help you with your treatment decisions, okay? And this is what it looks like, and we'll walk through kind of each step of this, okay? Markedly elevated blood pressure is the same as saying hypertensive urgency. It's just now in the ACC-AHA guidelines, they have changed the term hypertensive urgency. It's markedly elevated blood pressure now. But if you have hypertensive urgency, or you've diagnosed the patient with this, and you verify that there's no evidence of end organ damage, then typically you're going to look as to, well, why did this happen? The most common cause is they stopped taking their antihypertensives. And simply restarting them on oral medications is all that you need in order to treat this, okay? And the goal in the treatment is to get their blood pressure back down to normal within 24 to 48 hours. So we're not talking about minutes or hours to get this down. We're talking about days to get their blood pressure down to a goal range, okay? So look as to why this happened, restart them on their medications if they stopped it. Maybe you need to add an additional medication if they're taking it. But ultimately, they've got to follow up outside of the ER, preferably with their primary care provider, in a day or two to make sure that that blood pressure is coming down and also make sure that they haven't developed hypertensive emergency. Just because right now they aren't having evidence of end organ damage does not mean 6 hours from now they won't have that. Okay? It could develop, especially if you don't do anything to address that blood pressure. Okay? So counsel them when they leave the ER about the risks, signs, and symptoms of end organ damage and the need to come back immediately if they start experiencing those symptoms. Okay. So hypertensive urgency, treat with oral medications, treat as an outpatient, follow up with primary care. That's how you treat it. And reduce blood pressure in days. But let's look at the other side of the treatment algorithm, the hypertensive emergency side, where you have that evidence of end organ damage that's showing that that blood pressure, that severe blood pressure elevation is causing those other organs to be under stress. What do? Well, first of all, they're going to be admitted to the ICU. And the reason that they have to go to the ICU is you have to treat this condition with IV antihypertensives, which you can't do on the floor. You also need to do invasive blood pressure monitoring with like an arterial line so that you're having kind of a second-to-second blood pressure value, so you can see, do I need to titrate my dose up or do I need to titrate my dose down to maintain goal? Okay. You got to tightly regulate that. So that's why they're going to need to be in the ICU. A regular hospital floor cannot handle that. Okay. So you admit them to the ICU. You got to start giving them IV medications in order to lower their blood pressure to start to reduce that stress on those other organs. And you got a couple of different options out there. Okay, labetalol is commonly used. It's easily titratable. Nitroprusside is another one that we could use, or nicardipine is another one that we can use in an IV form to regulate or titrate the blood pressures down to goal. And you can see, here's a breakdown of these. The range, the normal dosage range of these medications is pretty broad. So I have wiggle room to adjust the dosage so that I can get my patient's blood pressure down to goal without causing an excessive reduction in their blood pressure. And we'll talk about why that's a problem in a couple of slides. But you can see I have these dosages ranges available to me that I can titrate easily to goal. So what is our goal? It kind of depends on, do we have, when you look at the algorithm and asks you to look for, is there a compelling condition? And what is a compelling condition? Well, severe preeclampsia, eclampsia, okay? Theo, talked about a Theo today, right? Or aortic dissection. If you have those, I've got it written out here, but if you want to look at the algorithm, you can see, yes, I have one of these conditions. If it's eclampsia, preeclampsia, or Theo, reduce the blood pressure to less than 140 during the first hour, and less than 120 if it's aortic dissection. So you want to be more aggressive if you have a ripping of the wall of the aorta. Okay? But you can see, within the first hour, I got to get them from that greater than 180 over 120 down to less than 140 or less than 120, depending on which compelling condition is present. Okay? If I don't have a compelling condition, but I still have this hypertensive emergency, then I take a more stepwise fashion to bring their blood pressure down. So within the first hour, I want to reduce their blood pressure no more than 25%. Because basically, I just want to get their blood pressure down to the point where now those organs are not under stress that's causing a dysfunction of those organs, okay? This patient probably is kind of accustomed to having an elevated blood pressure, so if I drop their blood pressure too quickly, I may precipitate now reduced perfusion and ischemia stress on that organ. And now the body starts to shut down because it's not getting the appropriate amount of blood to maintain function. Okay? So within the first hour, just reduce their blood pressure no more than 25%. Then, over the course of the next 2 to 6 hours, you're going to try to get their blood pressure down to the 160 over 100 to 110. So we're still not down to normal, and it's now been 6 hours, 7 hours. We're still not down to normal. We still are in stage 2 hypertensive range. We just now are out of that hypertensive crisis range. Okay. Once I get them down to that 160, then I have a couple of days to get them down to normal. Okay. So you can see this stepwise fashion, and this is critical because you don't want to overshoot your goal, which is why having those titratable antihypertensives is important, because I want to make sure I don't blow through that goal and drop it down too low, too quick, because that can cause pretty profound morbidity and mortality itself as well. Okay. Going back to the specific conditions, so we have those IV antihypertensives at our disposal, but if we have specific reasons or specific conditions that are causing that hypertensive emergency, we may have some additional medications outside of the IV antihypertensives to help us treat that blood pressure. And an example of this is aortic dissection. Remember, this is one of those compelling conditions that we have to be very aggressive in bringing down the blood pressure less than 120. Part of the aortic dissection and part of the reason they're experiencing that profound elevation in blood pressure is pain. So maybe we just need to give them something for pain to bring their blood pressure down. So first thing you should be giving to a patient with aortic dissection to help lower their blood pressure is give them morphine, give them Dilaudid, give them some narcotic in order to reduce their blood pressure. Morphine is kind of the preferred because you kind of get that vasodilatory effect as well, but treating pain is the most important thing. Now, once you've treated their pain, if they are still above that 120 goal that we have to get the patient down to within that hour, then you can start adding your labetalol, esmolol, those types of things to further reduce the blood pressure to get them to goal. Okay. If we have a patient who's coming in with a cocaine or an amphetamine overdose, and that's what's causing the hypertensive emergency, you don't want to give them a beta blocker like esmolol or labetalol, because you can get that unopposed alpha, and that causes the blood pressure to go up. So what do we do if that patient is coming in with hypertensive emergency? You got to get them to relax, right? You got to get rid of that hypersympathetic overdrive by giving them things to get rid of that sympathetic nervous stimulation. So Ativan, diazepam are great at helping reduce and getting that patient to relax. Okay. If they are coming in with an acute myocardial infarction, then you should be giving them nitro, right? Provided it's not a right-sided heart attack, right? Go ahead and give them nitroglycerin as kind of your first-line agent, because one, that will treat pain, but two, it also has that dilatory kind of effect as well, right? And that can reduce the heart attack that's happening. And when we talk about acute coronary syndromes, we'll talk about some of the consequences of that, one of which is the body detects that the heart is dying or heart tissue is dying, so it then stimulates the sympathetic nervous system to try to stimulate that cardiac output to try to improve your supply problem. But unfortunately, that also then increases our demand, and now you're in this balance of, is my supply going up enough to meet my demand, or is my demand coming up even more, and so it's minimizing my supply. So nitro will help with dilating and lowering blood pressure. But remember, acute myocardial infarction is not one of those compelling conditions that we have to be hyper aggressive about, right? It was just preeclampsia, eclampsia, and pregnancy. It was PHEOs, and it was aortic dissection, right? Those were our only compelling conditions. So somebody coming in with a hypertensive emergency due to a heart attack, your goal in that first hour is to get their blood pressure down no more than 25%. Okay? So don't think that acute myocardial infarction is one of those compelling conditions. It's not. Okay? So let's go back to our clinical encounter to kind of summarize now that we've talked about what happened with this patient, to see what further happened. So the patient was admitted to the ICU. They started her on IV antihypertensives to bring her blood pressure down because the clonidine patch was not adequate. So she had end organ damage because of the kidney function was disrupted, right? So they followed the treatment algorithm of 25% reduction within the first hour, then over the next 2 to 6 hours, bring it down to 160. And they were able to do that with the IV antihypertensives. The problem was, the following day, when they rechecked her kidney, the kidney function had deteriorated even more. So instead of it now being a creatinine of 2.0, it's now a creatinine of 3 point something. So this is showing you that this damage is ongoing or it's irreversible. Well, we don't have nephrology services at Belvoir, so we had to transfer her up to Walter Reed, and she required some dialysis, at least temporarily, in order to support her kidney functions. Okay, she started to have elevations of her electrolyte levels, like potassium, because the kidney function was disrupted. This was a 30-year-old something, very active marathon runner that didn't come in with rhabdo, because you kind of think about, okay, this is probably a rhabdo case, right? It wasn't that, but it was actually a hypertensive emergency causing kidney damage. And unfortunately, it was persistent and non-reversible, at least by the second day of her hospital admission. So I don't know what the exact cause was of this. I lost track of her once we transferred her to Walter Reed, but not something you want to be dealing with, unfortunately. So, questions? As you can see, we now have marked off all of our hypertensive conditions that we need to talk about for the PANCE blueprint. So we're making progress even more. Yeah.
So with the aortic dissection on vasodilators, does that have a chance to like go to rip because your restriction and pulling anything out?
Does it have a change with what? Sorry.
Like chance to rip it more, dilating and pulling out?
No, because what's happening is the rip is not necessarily occurring at the level of the media, the middle layer of the artery, which we'll talk about the layers of the artery on Thursday. The rip is occurring in the intima, which is the innermost layer. And so with the dilatory effect, you're reducing that pressure that's the dissection is, that tear is experiencing, but you're not really doing anything to reduce the strength of that muscle layer. Because the muscle layer is really where all that strength comes from with the walls of the arteries. So it's not like a complete tear where you're going through the 3 layers. You're just going through the intima. And we'll talk about it in the 6th lecture of this block when we talk about aortic dissection specifically. But what ends up happening a lot of times is you'll have bleeding into that space, which then leads to clot formation, which then leads to even more luminal narrowing, which then causes blood pressure rise, because it kind of is like a coarctation kind of picture that way. So yeah, so that vasodilatory effect only helps the condition without affecting the strength of the remaining wall. Yeah.
This might be kind of a long question, sir, but for emergency management without a compelling condition, even if the systolic was 200, say, 25% would take them below the 160.
Yeah.
So should you focus more on that first hour just being slow and getting it close to 160, or taking it to that 25-ish percent?
It says no more than 25%, so the goal would be just get it down to 160 in that case. So if, let's say 25% reduction is 150, don't shoot for the 150, just shoot for get them down to the 160. Because by the end of that 6-hour mark, that's your goal, is to be at that 160. So no lower than 160. Good question. Any other questions? Yes, I would. And the reason for it is, okay, they may have like a specific symptom that points to hypertensive emergency, but a lot of the other things that we do or test for to show that end organ damage, we may not be able to do in our primary care clinics. I can't do a basic metabolic panel to look at their renal function. I can't do a urine dipstick to make sure they're not having excessive protein or whatever release into the urine. So I may not be able to have the testing ability to look for some of those other signs of hypertensive, end organ damage. So yes, if you can't test for it, then absolutely it's appropriate to send them to the emergency room so that they can get those testing done to verify that they are in fact not experiencing hypertensive emergency. Any other questions? Sweet. So this is hypertension. Thursday when we meet, because tomorrow is our annual program review, so you all don't need to come.